Alteration in Neurological Function, Part 4. It's a rare degenerative disorder that involves the upper and lower motor neurons. You have axonal degeneration, demyelination, and scarring of your neurons that occurs. Symptoms are progressive weakness. Oftentimes, and there's no real pattern. It may start at the feet and work up. It may start in the head and work down. It may affect your vocal cords. Michael Zaslow was a very good actor. Broadway, soap operas, television. Excellent actor who lost his ability to talk because of ALS. Then he lost his ability to breathe, and then he died. Patients die from ALS because of respiratory arrest. Some can survive on a ventilator for a while. There is a football coach, high school football coach, out in Florida, who's on a portable vent. Out in California, who's on a portable vent, and he coaches the team by blinking the plays to his wife, who then tells the team what to do. And that way he's able to maintain his job as a coach. But these people will die because of respiratory arrest and the complications that go along with it. The sad thing about ALS is that intellectually they're normal. They understand everything that's going on with them. And their senses are normal. They feel the pain. They feel the pressure, everything else that goes along with it. And so it's a very sad disorder. Depression is very common in these people. Disorders that affect the peripheral nervous system and your neuromuscular junction. One of them is myasthenia gravis, which is a defect in the transmission of your nerve impulses at the neuromuscular junction. Acetylcholine receptors on the muscle cell's plasma membrane no longer are recognized as those from the body, so the body doesn't respond to them. And IgG eventually destroys the receptor sites. So this will cause fatigue, ptosis, which is drooping of the eyelid or a body part, diplopia, double vision, ocular palsies where the eyes shake and it's really hard to see, facial drooping, and dysphagia, trouble swallowing. When you have a myasthenic crisis, the patient goes into a respiratory arrest because they have the absence of acetylcholine. Now, I used to get myasthenia gravis and multiple sclerosis confused when I was trying to memorize the difference. Keep in mind the G comes before S, so myasthenia gravis starts at the head and works down, where multiple sclerosis starts at the feet and works up, if that's of any use to you. Now, there are some variant types, but that's the classic myasthenia gravis and multiple sclerosis. Tumors of the central nervous system. You can have primary intracerebral tumors that are called a glioma. They can be encapsulated or non-encapsulated. They account for about 40 to 77% of all brain tumors. And astrocytoma is the most common CNS glioma. It will infiltrate the surrounding brain tissue. An oligodendroglioma is a very slow-growing tumor, and an epididymoma arises from the epididymal walls of the ventricles. There's a table on page 398 that talks about the location, the characteristics, and the cell type for each of these tumors. And here we have our intracranial tumors that points out where they grow and where they tend to occur. Keep in mind, intracranial tumors are space-occupying lesions and can increase intracranial pressure and cause major problems that way, even if it is a benign tumor. Primary extracerebral tumors, an example of meningioma, is a benign encapsulated tumor. It does not invade the surrounding tissue, and it originates in the dura mater or the arachnoid matter of the brain. A neurolemma arises from the sheaths of the Schwann cells. It most commonly affects cranial nerve number 8. Spinal cord tumors can be intramedullary within the neural tissue or extramedullary outside the spinal cord. Symptoms are compressive syndrome, which will involve your sensory and motor function, your irritative syndrome, which causes cord compression and pain paresthesias, impaired touch, and impaired pain sensation. And the syringomyelotic syndrome, which causes pain and temperature tracts are affected, resulting in dissociated sensory loss, muscle weakness, and atrophy. Defects of neural tube closure usually result in death. They're due to genetic and environmental interaction. You'll have low folic acid levels in the mother. The maternal hyperthermia or blood glucose elevations will occur, or the mom is on anti-epileptic drugs. Posterior defects are more common. Now, anencephaly means they're without a brain. Remember, an and a mean without, and ceph is your brain. So this is without a brain. That's what it means. With anencephaly, the soft bony part of the skull and part of the brain are missing. This is an infant that is either stillborn or will die within a few days. And the head will have like a frog-like appearance. Anterior midline defects are when the brain are both brain and skull abnormalities. You'll have cycloplegia, where you have a single midline orbit and eye, a protruding nose-like appendage above the orbit. So they look like the cyclops of the old horror films. And here's a picture of anencephaly. This is the eye. This is the ear. This occurs in 1 every 1,000 births. There's no closure of the anterior portion of the neural groove. The vault of the skull is usually missing, and the cerebral hemispheres. The diencephalon and meningeal membranes are not developed and are usually represented by an exposed mass of undifferentiated vascular and dysplastic neural tissue. Acrania, the absence of the cranial vault, is always associated with this lethal condition. This is the lateral view of an anencephalic fetus, so it's looking at it from the side. This is cyclopia. As you can see, you have the single eye and the nose appendage. Encephalocele is herniation or protrusion of brain and meninges through the skull. It tends to occur mainly in the occipital area. It's also called a meningioencephalocele. This one is attached to the occipital area of the skull. You have anterior and other presentations may occur less frequently. This condition occurs about once in every 2,000 births. In encephalocele, there's a herniation of the brain into a sac lined by meninges and skin. A meningocele and a myelomeningocele. With the meningocele, you have a sac-like cyst of meninges filled with spinal fluid. It does not involve the spinal cord, and that's what the child looks like right here. You'll have a hernial protrusion of a sac-like cyst through a defect in the posterior arch of the vertebrae. This is another one. And it contains part of the spinal cord. It's associated with visual and perceptual problems, motor and sensory problems below the level of the injury. The skin defect is covered with a membrane that could rupture. The myelomeningocele occurs early in the development of the embryo, probably between the 20th and 28th day, well before most women even realize that they are pregnant. It's very common. A piece of tissue destined to become the spinal cord must, in that time interval, develop a groove and 2 folds which connect to form a tube. Failure to form the tube results in a neural tube defect, known as a myelomeningocele, when it occurs in the region of the spine. Neural tube defects, which occur in the central nervous system, will result in a more severe anomaly known as anencephaly, which is not compatible with prolonged survival. Babies affected with myelomeningocele, however, do survive and are usually born with a back defect visible at the time of delivery. Myelomeningocele is also commonly associated with the development of hydrocephalus, 90 to 95% of the time, as well as with a malformation of parts of the brain, the cerebellum and brainstem. That's called a Chiari II malformation. And this is showing our normal spine on the far left, the meningocele in the middle, and the myelomeningocele on the far right, as you can see spinal cord there. Spina bifida occulta, and there's a picture of it in the lower right-hand corner, is a single term that refers to a range of congenital abnormalities involving the lumbar and other spinal regions characterized by normal tissue placed in an abnormal location, resulting in tethering of the spinal cord into an abnormally low position. Individuals with spina bifida occulta frequently have skin lesions on the back which appear to be benign, birthmarks, but in reality are the warning of the disordered embryological development. The cause is unknown. They think it might be related to maternal low folate levels and genetic alterations. Their posterior vertebral lamina fail to close, and this is most often found in the lumbosacral region. It's found on ultrasound and with elevated levels of your AFP levels when you're intrauterine. Symptoms can be none, or you may have gait problems, muscle weakness of the lower extremities, bowel and bladder problems. It's suggested by the presence of the following: abnormal hair growth along the spine, midline dimple with or without a sinus tract, cutaneous angioma of port wine type, and subcutaneous mass similar to a lipoma or a dermal cyst. Spina bifida occulta includes many different types of problems, from very simple sinuses linked by skin which can enter the spinal canal and result in serious infection, to complex combinations of spinal cord, meninges, and fat tissue which adhere to the spinal cord. Other variations of this group of disorders include bony spikes which intrude between two halves of the spinal cord, and a spinal cord which end in a trumpet-like or flare of abnormal tissue, rather than in the usual tapering tip called the conus medullaris. These spinal problems are like myelomeningocele in that they can result in weakness of the lower extremities and difficulty with controlling the bowels and bladder. However, they are unlike myelomeningocele in that they usually do not occur with hydrocephalus and other brain malformations which are commonly seen in myelomeningocele. Another significant difference between the two disorders is that spina bifida occulta patients can have planned surgery because spinal fluid is not draining from an open neural tube defect. Surgery can be delayed for a period of time to allow the infant to grow. It is recommended that these congenitally abnormal spinal cords be released within the first 3 to 6 months of life if possible, and within a few months after detection in a child who is asymptomatic. Symptomatic children require more urgent intervention, as with any neurosurgical intervention in a person who is deteriorating. Cerebral palsy is the non-progressive syndrome causing motor dysfunction that begins in early infancy. The cause could be prenatal hypoxia or cerebral trauma. There are 4 different types. Spastic is when you have increased muscle tone, prolonged primitive reflexes, increased deep tendon reflexes, clonus, rigidity, scoliosis, and contractures. It occurs 70 to 80% of the time. Ataxic, you're going to have gait disturbances and instability. Hypotonia at birth with stiffness later on. This occurs 5 to 10% of the cases. Dyskinesia is an extreme difficulty of fine motor coordination and purposeful movements. The movements are jerky, uncontrolled, and abrupt due to damage to the basal ganglia or extrapyramidal tracts. This occurs about 10 to 20% of the time. And mixed, which is a combination of the 3, and this occurs about 13% of the time. And as always, you don't need to know percentages like that. That's just FYI. Cerebral palsy affects your gait, your muscle tone, and your reflexes. Sometimes you'll have seizures with it, intellectual impairment, they may have some intellectual impairment, but the majority of patients I've met that have cerebral palsy have been perfectly fine neurologically. They'll have visual communication problems possibly because of the motor involvement, bowel and bladder problems, orthopedic disabilities, and some respiratory problems. Oftentimes, these children will need lifelong care. On the other hand, some have gone on to become lawyers, physicians, teachers, So it just depends upon the degree. It doesn't have to be total, it can be partial. Phenylketonuria, also called PKU disease, is the inability to convert the essential amino acid phenylalanine to tyrosine. And phenylalanine is in most natural food proteins. Tyrosine is used to form the protein melanin, thyroxine, and catecholamines. So tyrosine is very necessary, but they're unable to do that. So this will result in problems with the central nervous system development, myelination, and degeneration of your white and your gray matter. There's a figure on page 412 that talks about the consequences you'll need to look at. Tay-Sachs disease, gangliosidosis, we also talked about when we talked about the genetic problems. This is an autosomal recessive disorder related to the deficiency of the enzyme hexa. 80% of the patients who get Tay-Sachs are Jewish. The onset is within 4 to 6 months after delivery, and death is usually by age 5. They will have developmental retardation, paralysis, dementia, and blindness. And there are screening tests that are now available for carriers. You need to use care because sometimes that becomes a pre-existing condition. Reye syndrome causes encephalopathy and fatty changes in the various organs, particularly the liver. It is the prototype for acute hepatic encephalopathy, and it can recur. Risk factors are infections with varicella, influenza B, an upper respiratory infection, gastroenteritis, or giving a child aspirin. There are 5 different stages. The first stage is vomiting, lethargy, and they're drowsy. The second stage, they're disoriented, they have delirium, they can be aggressive or combative, hyperventilate, shallow respirations, hyperactive reflexes, and stupor. Stage 3, they become obtunded, very difficult to arouse. Coma, decorticate movements, and hyperventilation. Stage 4, the coma gets worse. They now become decerebrate. They'll have decreased ocular reflexes, large fixed pupils, divergent eye movement. And stage 5 is, of course, the worst. They'll have seizures, loss of deep tendon reflexes, flaccidity, and respiratory arrest. Lead poisoning causes irreversible neurologic damage. Tends to occur in 2 and 3-year-olds with pica. Tends to be 5 times greater in blacks because these kids will ingest non-food substances like clay, dirt, or paint chips. And when you check their blood, they'll have increased blood levels of lead. These children may be chronically exposed to smelters, or they love to sniff gas, or they ingest airborne lead that might be in the room. It does cause irreversible neurologic damage, mental retardation in these children. Brain tumors in children. The most common solid tumor and the most common they are the most common solid tumor and the most common primary neoplasm in children. The cause is unknown. It can be associated with the parent's exposure to hydrocarbons. An astrocytoma is the most frequent type, and 2/3 occur in the posterior fossa of the brain. There's a table on page 417 that shows the different types and characteristics, a figure on 417 for their location, and a box on 419 for the signs and symptoms. It is the leading cause of death from disease between ages 1 to 15. Symptoms depend upon the area of the brain affected. They'll have an increase in intracranial pressure, headache, and vomiting that's worse in the morning than lethargy and irritability. The head circumference will increase. They'll have papilledema, cranial nerve palsies, and bulging fontanelles if they're under the age of 2. A neuroblastoma is an embryonal tumor that's diagnosed in the first 2 years. It's a sympathetic nervous system tumor that may spontaneously remit, go away. It has an unknown cause, but it's also been found to be an autosomal dominant gene variation. Symptoms are weight loss, irritability, fatigue, fever, diarrhea. You're going to have an increased level of your catecholamines and your serum ferritin, and that means it's a very poor prognosis. The serum ferritin is iron. You're going to have your adrenal medulla is where it's most often affected, this neuroblastoma. And the symptoms here would be an abdominal mass, if the neuroblastoma occurs in the mediastinum, the symptoms are dyspnea and infection. A retinoblastoma is an inherited eye tumor that occurs before the age of 1. It occurs because of an autosomal dominant gene in 40% of the cases. It's a cancer of the eye that represents 3% of childhood cancers. In the United States, only about 250 to 300 children per year are found to have this malignant tumor of the retina. The retinal tumor, which characterizes retinoblastoma, is malignant, meaning that it can metastasize or spread to other parts of the eye and eventually other parts of the body. In most cases, however, retinoblastoma is diagnosed before it spreads past the eye to other parts of the body, and the prognosis is quite good. The prognosis is poorer if the cancer is spread beyond the eye. Retinoblastoma can be inherited in an autosomal dominant gene, or it can occur spontaneously. Approximately 40% of people with retinoblastoma have an inherited form of the condition, and approximately 60% have a sporadic, not inherited form. Individuals with multiple independent tumors, bilateral retinoblastoma, or trilateral retinoblastoma are more likely to be affected with the inherited form of the retinoblastoma. If it's acquired, it occurs between ages 2 and 3. Symptoms are leukocoria, which is a white pupillary reflex or cat's eye reflex, strabismus, a red painful eye, and decreased vision. But if it's found early, more than 90% have a long-term survival. And here is showing leukocoria on the left and a malignant tumor on the right. And this finishes the neuro content. And this finishes the patho content, which I hope you have enjoyed this semester and have learned from.